have no disclosure. The overarching goal of PCSS-MAT is to make available the most effective medication treatments for addiction to serve patients in a variety of settings, including primary care, psychiatric care, and pain management settings. I hope at the end of this module, you'll be able to describe 3 examples of stigma and the way the medical system approaches substance use disorder. You'll be able to explain the importance of using medically appropriate language for substance use disorder, and to utilize effective terminology when discussing substance use disorder. So as an outline today, we're going to talk about substance use disorder as a prevalent but very treatable chronic illness, and really dive into stigma and the impact stigma has in terms of the care people receive and the ways in which clinical care often doesn't resemble what science shows us is effective, and then to talk specifically about the impact of language on stigma. Substance use disorder and unhealthy substance use more broadly is incredibly prevalent across the United States. We think just specifically about substance use disorder, nearly 1 in 12 adults had a substance use disorder in the past year. If we broaden that to all types of unhealthy substance use, in the past month, 1 in 4 U.S. adults engaged in binge drinking, and in the past month, 1 in 10 used illicit drugs. So that's many, many more millions. 58.5 million adults engaging in binge drinking, 22 million adults using illicit drugs, and then 20 million adults who actually have a substance use disorder. And particularly when we think about the current climate in public health and the health of our country, drug overdose deaths have now had a dramatic impact across the nation. More people now die from a drug overdose death than any cause under the age of 50, with overdose now being the #1 cause of death in this age group. And the peak number of drug overdose deaths has now surpassed the peak number of car crash deaths, the peak number of HIV deaths per year, and the peak number of gun deaths per year. So when you hear people talk about this as a crisis or an epidemic, the reason for that sort of language is really the scale of the toll this has had across our society. In fact, for the first time, we've seen in the past 2 years an actual decline in overall life expectancy across the United States, and that's in large part attributed to the ongoing crisis of overdose deaths. When we think about substance use disorder, it's important to define what we mean when we're saying that. And so we think of substance use disorder as a primary chronic brain disease characterized by compulsively seeking and using substances despite harmful consequences. So there's a couple important points in there. First, this is a chronic illness for most people, meaning that the goal is not cure, but rather to get people engaged in treatment and to get them into remission. And then it's fundamentally defined by behavior that can appear very irrational to those around the individual. And I think that's one thing that's so hard sometimes for family members or providers or the public to understand, because it's very easy to look at someone who's in the throes of active addiction and to think, why don't they just stop? Look at all these terrible things happening to that person in their life. And yet the defining hallmark of the disease is not being able to stop despite harmful consequences. It's also really important when we think about our response to people who use drugs and to addiction across our country, and the impact of stigma, because we've spent a long time as a society trying to punish people into getting well when we think about people who use drugs. People are sent to prison, they lose their children, they lose their jobs, they often lose contact with their family members. And yet the hallmark of the illness is not being able to stop using substances despite bad things happening to you. Making more terrible things happen to that individual is probably not going to be the pathway towards helping them get well. Because this is a chronic condition, it generally involves cycles of recurrence and remission. And like many other chronic conditions, it's highly genetic. We estimate about 40 to 60% of any individual's risk of developing addiction is based on the genes that they're born with. So what about chronic illness? How does that look different than a substance use disorder? Well, one definition of chronic illness includes first that it's long in duration, meaning it often has a protracted clinical course. And because of that, it's associated with persistent and recurring health problems. Chronic illnesses are generally multifactorial. They often have some component of genetics or biology and some component of environment or exposure or lifestyle. And there's no definite cure. So the goal, again, is to engage people in medical care, to get them engaged in treatment, and to hopefully minimize their symptoms and their consequences of ongoing illness. And so really, substance use disorder meets criteria for chronic illness. It shares many common features, including its heritability, talks about how it's 40 to 60% genetic. The fact that it's influenced by environment and behavior, much like many other chronic illnesses, such as diabetes or heart disease. And it responds to appropriate treatment, and that's a really important piece to mention. Too often when we talk about addiction, we talk about the devastation of untreated addiction, and yet most people with substance use disorder will recover, and the important thing is that they get effective and appropriate treatment. unfortunately, without adequate treatment, as we're seeing as people are dying across this country, this is an illness that can be progressive and can result both in substantial morbidity and mortality. And like many other chronic illnesses, there's a true biological and physiological basis. It's also ongoing and long-term, and it can involve recurrences. And so if we step back, treatment outcomes for substance use disorder are actually as good as they are for other chronic illnesses, and the course of treatment and response to treatment is quite similar. So if we think about recurrence or relapse, as some people talk about it with addiction, recurrence rates for substance use disorder are no different than recurrence rates for type 1 diabetes, for hypertension, or for asthma. If we define a recurrence as having ongoing symptoms of active illness that requires a change in the treatment plan, about 30 to 50% of people with type 1 diabetes, 50 to 70% of people with hypertension or with asthma have a recurrence over the course of a year. And when we look at someone with a substance use disorder, about 40 to 60% of people will have a recurrence who are engaged in treatment over the course of a year. And so those numbers are actually quite similar. And yet with someone with substance use disorder, we often see a recurrence as a sign of failure, either on the part of the individual or thinking that that person's never going to get better, when in fact, like another chronic illness, a recurrence really just signifies the fact that that person needs either more treatment or different treatment, and that the focus really needs to be on adherence and engagement. So not a black or white, someone is doing well or not doing well, but how do we keep someone engaged in care, and how do we modify treatment based on what that human being needs? We can also use functional imaging to see a lot of similarities between other chronic illnesses, such as heart disease, and chronic illness and substance use disorder. And we can actually see how biology is changed and how that then influences the symptoms that a person might have. So if you think about heart disease, we can use functional imaging to look at a healthy heart or healthy myocardium. And you can see the bright red throughout the heart muscle shows that the whole heart muscle is functioning normally and is able to pump uniformly. Next to it, you see the heart of someone who's had a large heart attack. And so there's an area of scar that's no longer lighting up red. And that part of the heart literally can't pump anymore because the muscle has been replaced by scar tissue. And that leads to the chronic illness we recognize as congestive heart failure. On the right side of your screen, you see first the image of a healthy brain, a brain without addiction. And you can see that the top part of the brain, the frontal lobes, are one of the most metabolically active parts of the brain, lighting up in bright yellow here. And that's the part of the brain that allows us to think about risk and benefit and delayed gratification and consequences. Sort of think of it simply as the braking system in the brain. It allows us to put the brakes on the deeper impulses we all have to do things that feel good or that are rewarding. And yet next to it, you see the brain of someone who in this case has cocaine addiction. And you can see that that part of the brain is literally underfunctioning. It's no longer lighting up in the same way. And so in a sense, you get a mismatch between the gas and the braking system in the brain, where the motivation circuitry, the reward circuitry, the desire to continue to use substances to feel better, to feel well again, has gone into overdrive. And the ability to pump the brakes to think, wait a second, if I do this, it's going to cause consequences in my life that I don't want to have happen, is not possible because that part of the brain is under functioning. And so we would never look at the heart on the left side of the screen that's ill with congestive heart failure and ask the human being that has that heart to just choose to make their heart pump harder. And yet too often we look at the brain on the right and ask the human being that has that brain to just choose to stop using drugs or just choose to get well again, and not really treating addiction the same way as we treat other chronic illnesses. So if we begin thinking about addiction as a chronic condition, outcomes from treatment are actually very similar, and the nature of how the course of treatment over the long term plays out is very similar. So if we think about an example of hypertension, we would expect that before treatment, someone's blood pressure would be high and their condition would be severe. And during treatment, a majority of people would have a response, and we'd see a significant decrease in the severity of their condition. And yet, if you were to prematurely stop treatment, you would predictably see that a significant number of people would have a rebound in their symptoms and their blood pressure would go up again. With addiction, we see the same thing, that with good treatment, a majority of people will get into remission and have a significant reduction in the severity of their symptoms. And yet, if treatment is prematurely terminated, we see a significant number of people experience a recurrence in the severity of their symptoms. And yet, too often, again, when this happens with addiction treatment, we blame the patient or we get hopeless, nihilistic about outcomes, rather than simply seeing this as a chronic illness that requires ongoing care. The great news with addiction also is that we can actually see recovery happen. We can actually see improvements happen over time. So in this functional imaging looking at dopamine transporters in the brain of people with and without methamphetamine use disorder, you can see on the far left a healthy brain where you see again that bright red uptake, looking at dopamine transporters. In the middle, you can see the diminished function in the brain of someone with methamphetamine use disorder. But next to it, you can see that those changes, many of them do remit, and you actually see normal function return. But in this study, that normal function returning took 14 months of treatment and recovery before those changes normalized. And the brain in the middle, that still looks so different from the brain of someone who does not have a methamphetamine use disorder, is actually the brain of that person at 1 month of abstinence. And so if you think about our treatment system, where we've built a system that often approaches addiction as if it were an acute process that can be fixed with a few weeks or 30 days of treatment, that brain in the middle is what it looks like at the end of 30 days of treatment. And so we essentially have this mismatch. We know from science that substance use disorder is a chronic illness, and yet we built an entire treatment system that approaches it as if it were an acute process that responds to episodic treatment. So what is effective treatment? Well, it looks a lot like effective treatment for any other health condition. First and foremost, it has the human being at the center of it, who's involved in deciding what sort of treatment is most effective based on their own preferences and their own history and the severity of their illness, and guided by a well-trained clinician. There's an assessment process that leads to diagnosis and a treatment plan, and that plan often includes some combination of medication, behavioral support, other recovery supports like peer support groups, ongoing monitoring and follow-up, and then clinical and case management. And surrounding that person is the need to address all of the other components of that individual's life. So addressing what's going on with their housing or their transportation. Do they have legal issues? Do they need other sorts of mental health or medical services? Do they need help around childcare, vocational services? I think with HIV, we really recognize the need to address the many other competing priorities in the individual's life and social determinants of health if we're going to effectively treat their HIV, or similarly with diabetes. And yet, too often with addiction, we don't really attend to the many other needs of the individual as we think about treatment planning. More specifically, with substance use disorder, effective treatment usually includes some combination of pharmacotherapy, psychosocial or behavioral interventions, and recovery supports, depending on the individual and the type of substance use disorder. In terms of pharmacotherapy, we have medication treatment for alcohol use disorder, opioid use disorder, and tobacco use disorder. We don't have any FDA-approved pharmacotherapy for cocaine use disorder, although there have been studies looking at certain agents with some modest efficacy, although that varies from study to study. In terms of psychosocial or behavioral interventions, we can think in terms of the level or intensity in which the care occurs. So outpatient versus an intensive outpatient program, or a partial hospitalization program, or even a residential program. But more importantly, what is the modality that's being employed? Is an evidence-based modality of treatment a part of the intervention? So thinking about what's effective with substance use disorder, we know that cognitive behavioral therapy, motivational interviewing or motivational enhancement therapy, contingency management, and 12-step facilitation are all effective modalities. And then recovery supports are not formal treatment, but can be a really important adjunct to formal treatment. And these include things like mutual help or peer support groups, such as 12-step groups or smart recovery or other types of peer support. And then increasingly, systems and programs across the country are using recovery coaching, the use of people who themselves have lived experience, who are peers in recovery, who can provide really crucial support and navigation to an individual. And so this is all actually very similar to how we manage other chronic illnesses if we think about diabetes or HIV. So with both those conditions, there's no cure, similar to substance use disorder. But the goal is to get someone in treatment, to get them into remission, because we want to try to prevent the acute and chronic complications of untreated disease. The reason we care about what someone's blood sugar is not because there's any particular value in that specific number. It's because we know that people with higher blood sugar are more likely to have complications such as vision loss or renal failure or losing a limb to amputation. And we want to prevent those negative complications both in the acute setting and chronically. And similarly with substance use, the reason that we care about whether someone is continuing to use substances is not necessarily a value judgment about the use of substances. It's really because we want to prevent the acute and chronic complications that go along with ongoing use, such as acute overdose or chronically infections related to injection use or liver disease or social impairment. If you think about other illnesses like diabetes or HIV, we have decades of science showing us what's effective and what clinical targets we want to aim for, but we then tailor that treatment to the human being in front of us. So if I'm in clinic and I see a patient with diabetes and I really think they should start insulin, I may recommend that. But if the person tells me that they're terrified of needles and there's no way they'd consider insulin, but they're willing to consider an oral medication, I would work with that person and start with where they are and continue to partner with them towards a path of health, towards health. And yet, unfortunately, too often in addiction treatment, care is made to be black or white, that people have to take it or leave it. And if they're not willing to accept every component of a recommended treatment plan, too often they're accused of being not motivated or not ready or non adherent or even kicked out of care. The other similarity is what types of interventions can be effective and the way we tailor that to the individual. So if you think about diabetes, many people can manage their diabetes with behavioral interventions or lifestyle change alone, and other people can try just as hard and they need long-term medication treatment. Similarly, with opioid use disorder, the most effective treatment we have is medication treatment, and yet some people can get into remission and effectively manage their illness with behavioral support alone. And so all options need to be available to the individual patient and tailored to that person's preferences and their treatment history. Other important components are really ongoing and regular monitoring. So we would never start insulin for a patient and then never see that individual again. We would continue to monitor that person closely, and as they get well, we would space out the interval of monitoring. And yet, too often with addiction treatment, we see these small episodes of treatment rather than ongoing follow-up with recovery checkups. And so how long should treatment last? Well, with other chronic illnesses, we see ongoing treatment and ongoing engagement in care or being on medication therapy as a success, as a sign of a person being in recovery, of being committed to their care, and that's really a positive outcome. And yet, unfortunately, too often with addiction treatment, particularly around medication treatment, we somehow see long-term treatment as being a bad thing, as if someone should come off treatment rather than stay engaged in care. And when we think about what's recommended for people with substance use disorder, in many cases, treatment does need to be long term, and in some cases, it could even be throughout life. And the goal of treatment services is, of course, to help someone stop or reduce their substance use, but also to improve their health, their social functioning, and to prevent consequences of untreated substance use disorder. And so, similarly to how we would really view being on ongoing therapy for diabetes as a success and a cost-effective way of prolonging life and improving the quality of care and of life, we need to have the same perspective when we think about substance use disorder. Other lessons I think we can take when we think about the comparison between substance use disorder and other chronic illnesses come from kind of system-wide responses to different public health crises. If we think about HIV/AIDS, it's really remarkable looking back at the past several decades where we've transitioned from a time when HIV was essentially a death sentence to now a world in which, for many people in this country, HIV is a chronic illness that can be managed with a single pill a day, and where some people are even predicting an end to the HIV epidemic globally. And when people talk about that, they talk about this equation of testing more, meaning identifying people early, not waiting until someone is very, very sick to identify them, getting them on treatment early, and then helping them stay safe. And a similar equation can be used if we think about the current overdose crisis. So, for example, we need to be identifying people when they're first having problems with substances, rather than waiting until they have the equivalent of an opportunistic infection or stage 4 cancer. So really identifying people earlier in the course, and then getting people aggressively engaged in treatment. Within HIV, there's an understanding of treatment as prevention. And if you get a person on treatment, you're actually not only helping that individual, but you're having a preventative impact on the community. And the same could be arguably true of people with substance use disorder. That helping one person, getting them into remission, reducing community exposure to ongoing substance use has a preventative effect as well. And then third, with HIV, we've been very open and supportive, importantly now, of harm reduction interventions. How do we help people stay safe? Thinking about syringe exchange programs, about condom distribution, about pre-exposure prophylaxis. And the same is crucial when we think about substance use disorder care. We absolutely want to make sure treatment's available and accessible, but we also need to help people stay safe from the consequences of ongoing use. And so thinking about overdose prevention and education and naloxone distribution. Think about syringe exchange programs and safer injection practices, and even supervised consumption sites. There's many different ways to think about how to help people stay safe. And then the other important thing is when we think about stigma, and this is a wonderful quote from the executive director of UNAIDS about the impact of stigma and shame, that whenever AIDS has won, when we haven't been successful in containing HIV/AIDS and getting people on treatment, it's really been when stigma and shame and distrust and discrimination have been leading. And when we've been successful, when we've been able to have a public health response, it's been because the opposite, because of trust and dialogue and support and solidarity. And the same is true when we think about substance use disorder. When we think about our history across this country, about policy and practice, unfortunately, stereotypes and stigma continue to influence it. This is a wonderful quote by Dr. Dole, who was, of course, the physician that discovered methadone as a treatment for opioid use disorder. In this interview, he was reflecting back on his own career, and he talks about how for him, the most educational experience of the past 3 decades was to learn that the traditional image of the person with addiction as being weak or hedonistic or unreliable or dangerous is totally false. And yet this myth, believed by the majority of the medical profession and the general public, has distorted public policy for 70 years. Hopefully we're beginning to see a shift away from that, with talk of addiction truly as being a public health issue, and yet still we can see playing out in our public policy and in clinical practice throughout our system the ways in which that stigma and those stereotypes have influenced both clinical practice and also policy. And yet we've made huge advances in the science of addiction and treatment. This image is from a wonderful article in the New England Journal of Medicine by Dr. Volkow and Dr. Collins, the head of NIDA and the NIH, respectively. And they talk about the importance of science when we think about responding to public health crises. And if you think about any public health crisis, be it HIV or Ebola or obesity, it's really science that's allowed us to resolve public health crises and get our arms around epidemics. And when we think about the current epidemic of overdose death, really will be no different, that we need to translate our science into clinical practice and actually use science to fight stigma. And yet, despite all of those amazing scientific advances that Dr. Volkow and Dr. Collins highlight, we continue to see a profound gap between what we know from science and what actually happens in current practice. And this really is a result of marginalizing addiction as a social problem or a criminal justice problem rather than a medical condition, as this report from Casa Columbia highlights. And as they argue, much of what we call treatment in the addiction world looks nothing like treatment for other health conditions. And frankly, if we treated people with other health conditions the way we treat people with addiction, it would probably be malpractice. So what might that look like? So it's a thought exercise. What if we treated other diseases the way we treat substance use disorder? What would that look like? So imagine you go to the hospital with chest pain and you're found to be having a heart attack, and you were told it's your fault because of your choices. Maybe you have a high stress job, maybe you haven't been exercising, or maybe you haven't been eating well. You were denied treatment because you did it to yourself and you're to blame. If you're lucky, maybe you got a list of cardiologists or catheterization labs to call on your own. You're only given life-saving medication if you agreed to first go to nutrition counseling. And if you had a recurrence of your illness, you had more chest pain, you were actually kicked out of the hospital. So that, of course, sounds ridiculous and silly, because we would never treat someone with heart disease or with chest pain this way. And yet this is the experience people with addiction have every day. And so what might it look like if we instead treated substance use disorder the way we treat other diseases? So first, the only prerequisite for treatment would be having a substance use disorder, and we would build a system that offers treatment on demand. When we think about the rest of our healthcare system, we triage care by trained clinicians who go to years of medical or nursing school to understand how to triage patients and to identify the right treatment for the right patient. And we have an entire system that then supports patients in that process. And we can determine whether the person who comes in with chest pain to the emergency room needs to go to the cardiac ICU, or whether that person can be followed up in primary care. And yet too often in the addiction system, care is triaged based on who you know, what connections you have, what resources you have, and often the people who are the sickest, who need treatment the most, are the least likely to be able to access care because of the way the system is set up. We would never fire someone for having symptoms of the disease, so for having a recurrence. Unlike that person with chest pain, we don't kick people out of the hospital when they have another heart attack. We embrace them into the system and enhance their care, and yet still many treatment programs will respond to someone who's having a recurrence of drug use by actually kicking them out of care. We would encourage people to go on life-saving medications. We would make that process easy rather than onerous. And we would offer people a menu of treatment options. We wouldn't make things all or nothing. We would let people be involved in their treatment decision planning and make treatment decisions based on their preferences and their personal experience. So why doesn't care look like that? Why does care look so different? Well, in a simple word, because of stigma. A World Health Organization study looked at 18 of the most stigmatized social problems across 14 countries and found that drug addiction ranked number one out of all 18 conditions. So drug addiction was considered more stigmatizing than being a criminal, than having HIV or many other conditions, and alcohol addiction ranked number four. So this continues to be a highly stigmatized condition globally. We know that people who experience stigma have worse mental and physical health outcomes than those who don't. And stigma is one of the main reasons that only 10% of people with substance use disorder access care in a given year. So, what exactly is stigma? Well, stigma is defined as an attribute, a behavior, or a condition that is socially discrediting. So it's a way, in essence, of creating us versus them, of isolating a person or a group of people and doing what I would call othering, creating some separation between us and those people. And we see that all the time in individuals with substance use disorder. And there's really two main factors that influence stigma. And I would call that cause and controllability, meaning do we think that someone was the cause of this condition, and do we think it's under their control? And we know that stigma decreases when a person thinks, well, it's not his fault, or when we think that an individual can't help it. And so this gets to why it's so important that people have a concrete understanding that's based in science of what addiction is, because too often, still, both clinicians and members of the public think that people can control their substance use disorder and that they're to blame, that they somehow chose to have this condition and that they could stop if they want to. And because of those misunderstandings about addiction, we see stigma really be heightened. The other thing that I think contributes dramatically is the language that we use. So if you think about the language we use for people with other illnesses, we use terms like survivor, patient. We talk about patients suffering from an illness, being afflicted, they endure their illness, they're a victim, they're a fighter. So really language that anchors that person as being the victim of their illness, as being sort of something happening to that individual rather than them being to blame. And then if you contrast that with the language we use for people with a substance use disorder, we call people abusers, substance abusers. We label them as addicts. Even worse, sometimes we hear people refer to someone as a junkie. We talk about substance abuse. We refer to people's toxicology as being dirty, or we refer to people who are in recovery as being clean. And all of this is language we would never use with another health condition. So we would never say that, I'm sorry, Mr. Jones, your blood is dirty with cholesterol, because that sort of language could be very offensive, and that's not the kind of terminology we use in medical systems. And we don't label people by their illnesses. We use what we call person first language. So I would never say, I'm going to see the breast cancer in room 34. I would say I'm going to see Mrs. Smith with breast cancer, because we recognize that people are people first, and they may have an illness, but it doesn't define them. And yet, too often with substance use disorder, we label people. We call them substance abusers or addicts as if that's the only thing that defines that individual. And we think about what language in particular is so problematic. I think abuse is a very problematic term. First, if we look at where it came from. So abuse is derived from an Old English word that means a wicked act of practice, a shameful thing, a violation of decency. So not exactly a word that we want to use when we're talking about a medical condition. And indeed, we don't refer to people who have an eating disorder as being food abusers, or someone with diabetes as being a sugar abuser. So this is language we really don't use for other health conditions. It's also a term that's associated with a really terrible volitional behavior like rape, domestic violence, and child molestation. Not medical conditions, again, but really violent acts. And this may sound like semantics or like an issue of political correctness. There's actually been really interesting research looking at highly trained clinicians, so master's level therapists or PhD level clinicians, where if you give that individual a vignette describing a patient, and the only thing you change is from describing the patient as a substance abuser or as a person with substance use disorder, the clinician is more likely to recommend punishing treatment if the person is described as a substance abuser. Similarly, the public is affected by language. Surveys have shown that if a person is described as a drug addict, they're viewed much less favorably by the public than if someone's describing as having a drug use disorder. And we know that when people hold more stigmatizing views of addiction, they are much more supportive of punitive policies. So all of this language actually translates into clinical care and decision making. It translates into how people think about policy and how people support or don't support policies. And so there's really broad reaching effects from the effects of language. And then, of course, why does stigma matter? Why do we care if language is enhancing stigma? Well, we know that there's many different types of stigma disorder that have broad-reaching implications and impact. People with substance use disorder may face stigma from within. Often they've internalized many of these external misunderstandings and stereotypes about addiction. They might blame themselves and feel responsible, and they might feel hopeless that they're never going to get well. Within the recovery community, there's actually quite a lot of stigma about different types of treatment. So even though it can be a wonderful source of support and peer support for individuals, some folks, particularly those on medication treatment, might actually feel stigmatized around this debate between medications versus non-medication treatment. People might experience stigma from clinicians. Many healthcare providers themselves feel quite hopeless about addiction and may hold the belief that treatment is ineffective and may not really know what the science shows. And then there's stigma from the outside, from the general public, particularly around whether this is a choice, whether someone is to blame for their condition, or whether this is an illness or a disease. So what are some examples of stigma, particularly within the healthcare setting? Well, people with substance use disorder, and particularly those on opioid agonist therapy, such as buprenorphine or methadone, are frequently not accepted to post-acute care facilities. So, for example, if a person on buprenorphine is in the hospital and needs to go somewhere to get long-term antibiotic therapy, they often have very little or no options because standard nursing facilities won't accept them simply because of their condition and the fact that they're on this medication. Similarly, people with substance use disorder and those in remission on agonist therapy may not be offered organ transplantation, depending on the care setting and the type of organ. And then we still see, despite all of the conversation about how this is a public health issue and how we can't, quote, arrest our ways out of the overdose crisis, we continue to see that people who have positive toxicology during probation, when one of the conditions of their probation is sobriety, will actually be imprisoned, rather, even if they're engaged in treatment. So even if they're following all of the recommendations for treatment, if they have a symptom of their illness, they're actually sent to prison. And so what's the impact of stigma? Well, obviously it has huge impacts if you think about the impact on our criminal justice system, on our health system, on our housing and employment system. It erodes the confidence in the public and amongst clinicians and patients that substance use disorder is a valid and treatable health condition. It can be a huge barrier to jobs or housing or relationships or custody. It can deter the public from wanting to pay for treatment and allows insurers to get away with not covering it. And we know that it's one of the main reasons that people don't seek help. And it also impacts both clinical care and treatment decisions. So what can we do to change our language to improve care? Well, there are certain words that we should absolutely avoid. So words like dirty, clean, abuse, abuser, and any terminology that's not person-first language. So referring to someone as an addict or an alcoholic, and really using the same type of language we've used for other health conditions. There are even some words that aren't outright offensive and are quite common that we could consider changing. So if you think about medication-assisted treatment, that's terminology we don't use for other health conditions. So we don't talk about insulin-assisted treatment for diabetes, even though, of course, behavioral interventions are crucial with diabetes care as well. And so implication there can be that medications are not somehow a valid component of treatment. We talk about detox, which is a really medically inaccurate term and can be stigmatizing when what we really mean is medically supervised withdrawal. And so those would all be some examples of language to change. Some institutions have really taken this on. So Boston Medical Center, through their Graken Center for Addiction, has been a real leader in this and actually had a pledge that they asked all of their staff members to sign to help stop stigma associated with addiction through changing language. You can see they recommend many of the changes that we've already talked about. So using person-first language, like a person with a substance use disorder, and avoiding any terminology that uses abuse or abuser, and any terminology that isn't person-first, so calling someone an addict or obviously a junkie. They talk about avoiding sort of non-specific and non-medical terminology like drug habit or abuse, and using, again, medically specific language like substance use disorder, addiction, risky or unhealthy use, and not referring to people in recovery as being clean, which implies that people who are still actively using are somehow dirty. When we talk about medication treatment, they also recommend getting away with medication-assisted treatment or substitution or replacement therapy, both of which can really spread misinformation and perhaps stigma around the use of medications in the treatment of substance use disorder, and instead just calling it treatment or calling it medication for addiction or medication for addiction treatment. And then when talking about toxicology results, talking about them as being positive or negative or appropriate or inappropriate rather than clean or dirty. And we know this is especially crucial because even though the science is very clear that medication treatment is effective, many people, including some policymakers, some people in the criminal justice system, and even some treatment providers, continue to view medication treatments like methadone or buprenorphine as simply substituting one substance for another, and therefore only support or spread an abstinence-only philosophy that can be incredibly damaging when we know the life-saving potential of these medications. And this has direct impact. Stigma around medication treatment may be one reason that so few physicians are waivered to prescribe buprenorphine. This is a 2015 study that looked at the percentage of physicians practicing in the United States that had a waiver to prescribe buprenorphine. And you can see that among all physicians, only 2.2% had a waiver to prescribe buprenorphine. And although that has slightly improved, it's still only around 4%. And of those, many don't even end up prescribing the medication. And that really gets to the need for change, and that it's simply not enough to have the existence of buprenorphine to create a sea change around addiction medicine and around treatment, but rather we really have to examine the impact of stigma on ourselves as physicians and care providers. This is a wonderful quote by Walter Lang in a perspective piece he wrote, where he talks about the fact that, we as physicians or healthcare providers are affected by the same stigma and attitudes that everyone else is. And this notion that people with addiction have somehow brought upon themselves suffering that they're experiencing, and that even as we've begun to change a bit and talked about addiction as a disease, many of our policies continue to reflect those underlying stigmas that, yeah, maybe people are sick and maybe they need help, but they also have done something bad. And so therefore we can't help them too much. We have to make it a little bit hard on people. And we see that again and again in the way our treatment systems are developed, the way our care models are developed, and the way patients are treated. And so if we truly want to make buprenorphine effective or make treatment effective, we need to fundamentally change the way that we as healthcare providers and physicians understand and think about addiction and people who use drugs to be able to create that sort of change. We know language and approach are crucial when caring for any patients with substance use disorder, but particularly some of our most vulnerable patients. So one example is hospitalized patients with substance use disorder. Many of our sickest patients don't come into the healthcare system until they're in an acute crisis and they really can't avoid it. And so often in the hospital setting, we may see people that are completely disconnected from the healthcare system and suffering from very severe substance use disorder. And the way that we talk about and talk to and approach those individuals, particularly when it comes to managing withdrawal or pain and their medical care, matters tremendously. This was a wonderful piece in Addiction published in 2016. That was a qualitative study of individuals who, with opioid use disorder, who've been hospitalized, sharing their experiences in those hospital stays. And many of them talked about the same sort of themes. As you can see from the first quote, the individual saying that if they hadn't been so sick, if they hadn't been experiencing untreated opioid withdrawal, and if they had felt like the medical providers were just listening about their needs, that they would have stayed in the hospital and not left against medical advice. Similarly, the next case is a person saying, I wouldn't leave the hospital. It would make me want to stay and deal with my medical issues. And that they know a lot of people go to the hospital and then end up leaving because they want to do drugs. So really emphasizing the importance of treating people with compassion, but really addressing their untreated withdrawal, their craving, their need for treatment for their opioid use disorder. And then the last one, really framing an approach to someone in the hospital who uses drugs, of asking the person, do you need anything? Are you using anything? And recognizing that people who use heroin or other opioids have needs, will have withdrawal that can go untreated, and that they have pain that needs to be treated. And as this person points out, if you're a person with opioid use disorder and you go in the hospital and they don't give you anything, how are you expected to stay? We also know that hospitalized patients with substance use disorder are very fearful based on their prior poor experiences. And so they bring into their healthcare experience the fact that many times they've been treated poorly in the system before. And so healthcare providers, in some ways, need to go above and beyond, recognizing that this marginalized population has often been quite traumatized by their experiences with healthcare providers. In this study, many patients described, particularly their treatment of pain and withdrawal, as being extremely variable, and that inconsistency being really challenging. As this quote described, the last time they took me to the operating room, put me to sleep, gave me pain meds, and I was in and out in 2 days. This crew is hard. It's like the Civil War. Not exactly how we want people to be describing their medical care in the hospital. And then some patients are fearful that if they're honest about their drug use, they'll be treated differently or even punished. This patient recounts letting his team know that he was on methadone and that he would need methadone while he's in the hospital, and hearing one of them actually laugh at him in a negative and condescending way, and how painful that is when you're already feeling sensitive and vulnerable, going into a healthcare system hoping that you'll be treated well and being treated differently because of your history. And that sense from patients that it really feels like the healthcare team's on one side and the patient is on the other side. So, what can clinicians do? Well, first, if you're a physician or a nurse practitioner or a physician assistant, you can get waivered so that you can offer science based effective treatment for substance use disorder. When we think about the current overdose crisis, we know that treatment with buprenorphine or methadone reduces overdose death by more than 50%, and we can quite literally save lives by making treatment more available. But we can't make office based treatment more available unless providers get waivered. And so utilizing all the excellent resources across the country, particularly by PCSS-MAT, to be able to get waivered and get this training to be able to save lives. We can speak out against stigma and discrimination. We will all unfortunately see this frequently in our life and in our work. And then we have a real opportunity to speak out, to be advocates, and also to educate our fellow providers, our family members, the public when we see this sort of stigma and discrimination happening. I think importantly, we can keep hope alive. We talked about how hopeless some patients can feel, particularly when they've internalized this sort of stigma. And so, one of our most therapeutic interventions may actually be holding that hope for people, helping build up their sense of self efficacy and their belief that they will get well. And then, as we've talked a lot about our language and being really mindful of language, using person centered, medically appropriate terminology whenever we talk to a person with substance use disorder or a person who uses drugs or about substance use disorder. And then lastly, like we do in any other arena of healthcare, we can treat affected individuals with dignity. We can respect their autonomy and their perspective and involve them in the systems of care that are meant to help them. What about family members or friends? Well, first, really importantly, for family and friends to learn about addiction, to understand what science says. This is a wonderful article in the lay press by Maya Solovitz, who's an incredible journalist in recovery herself, entitled "What Science Says to Do If Your Loved One Has an Opioid Addiction." I frequently share this with patients or with their family members, and it's a really wonderful, quick read highlighting some of the key points. So, learning about science, what does science show about treatment? Learning about how to intervene gently. Many family members have been fed this false notion of tough love, that they need to somehow be hard on their people that they're in relationships with who have substance use disorders, and yet the data really doesn't support that tough love approach. And confrontational, harsh interventions are almost always destructive, both for the family and for the individual. And then helping families remember that relapse isn't failure, that a recurrence is a part of managing a chronic illness and just indicates the need for ongoing treatment. So I've listed here all of my references from the different slides for your reference or to go back to. So feel free to turn to those. And then I just wanted to make sure that everyone was aware of two really wonderful resources that are offered through PCSS that may be of interest to you. The first is the PCSS Mentor Program, which is designed to offer mentoring assistance to anyone who's in need of more one-on-one interactions with a colleague around a clinical question. So through this program, you can either request a mentor from the mentor directory, or you can be paired with one through the program. And to find out more, please use this link. It's a really wonderful opportunity, particularly for new prescribers or really anyone who wants some extra assistance in managing a patient or a clinical issue. The next is PCSS offers a discussion forum, which is made up of PCSS mentors and other experts in the field who can provide prompt responses to any clinical cases or questions. We always have a mentor on call each month who can address any additional questions that are submitted through the discussion forum. And you can create a new logon account by linking here on the image in the slide on the registration page. We hope you'll take advantage of that. Listed here is a slide that simply shows the consortium of lead partner organizations that are a part of the PCSS project, just to highlight all of the many organizations that are involved, as well as contact info for PCSS, what the website is, what the Twitter and Facebook handle are, so you can follow along on social media and learn more about what they offer. Thank you very much.